Thank you very much for the kind introduction, and it's fantastic to be here in Tokyo. So over the next 20 minutes, I'm going to talk about advanced HIV disease as a neglected disease and give some updates on a landscape mapping report that we did at the World Health Organization. So over the course of the talk, I'll give a bit of background to what advanced HIV disease is. I'll discuss why we're still seeing advanced HIV disease when we have highly effective antiretroviral therapy widely available across the globe. Why are people still dying? What can we do about it? I'll talk you through our World Health Organization report and what the findings were, and talk a bit about the ongoing challenges, which I think are going to increase rather than decrease over the next few years for reasons that are probably fairly clear to most of us. So, what do we mean when we talk about advanced HIV disease? Well, this is the World Health Organization definition. It's a CD4 count of less than 200 or WHO stage 3 or 4 disease in adults and adolescents, or any children younger than 5 years of age who are not on suppressive antiretroviral therapy. And many of you will read that definition and think, well, that's exactly what we used to call AIDS, and you'd be right. So basically, advanced HIV disease and AIDS are synonymous. The terminology advanced HIV disease was developed to try and be less stigmatizing, although it turns out that lots of people in the community living with HIV actually prefer us using the term AIDS. So we currently use both. And if you go back to the beginning of the HIV epidemic, this was what people were concerned about. AIDS was what we were trying to prevent. AIDS was what we were seeing in clinics and hospitals around the world. And these were the kind of images that became associated with HIV, people developing very severe opportunistic infections, people developing wasting syndromes. These are pictures from 2 books by somebody called Gideon Mendel, who's a photojournalist, well worth reading. The one on the right is a picture from the UK, from a hospital in the late 1990s, where it was primarily young gay men who were becoming critically unwell with opportunistic infections. The picture on your left is from Africa, and early on in the AIDS epidemic, it became apparent that many, many people were dying in Africa from HIV-related illnesses. And the scale of this really was quite catastrophic. So these are data from southern and East Africa. This is simply showing life expectancy, and you can see a catastrophic decline in life expectancy across the region in the early to mid-1990s. The country that I've spent most of my career working in, Botswana, is shown in red. And you can see that by the early 2000s, the average life expectancy had fallen to just 37 years in Botswana, all as a result of a single infectious disease, HIV. So this really was a catastrophe. And the then president of Botswana, Festus Mahai, went to the United Nations and made quite a famous speech where he stated that his people were really threatened with extinction. And he called on the global community to step up and provide assistance to try and stop so many people dying of this disease. And the global community did step up. The response to HIV really was one of the great global health successes of our generation. The development of antiretroviral therapy, really a medical miracle, which I think is still underappreciated. And it was rolled out widely and across Southern and East Africa. Many, many people were put on treatment over the course of the 2000s. In Botswana, by 2018, they'd reached the UNAIDS then 90-90-90 targets. They had 81% of people on suppressive antiretroviral therapy, so really a huge success. And the narrative around HIV and AIDS changed from those highly stigmatizing pictures of people dying of opportunistic infections to this kind of messaging. This is a public health message from Southern Africa, and it's showing that you can live a perfectly healthy life with HIV, just 1 tablet a day. You can have a normal life expectancy. You can have a normal sex life. You're not infectious to your partners. It really was a change in message, a change in narrative, a way to try and destigmatize those earlier ideas about what HIV and AIDS meant. But even though the modelling was suggesting that HIV should really disappear and deaths from HIV should disappear with rollout of effective antiretroviral therapy, unfortunately that's not what we saw. So this was a very influential model called the Greenwich model, which was one of the things that led to the rollout of Treat All across the globe. And if you look at the bottom figure there, which is the number of deaths per year, you can see that in all of the model scenarios by now we should virtually be seeing no deaths at all from AIDS across the globe if we rolled out Treat All. But in Botswana, which, as I said, has been very effective at rolling out antiretroviral therapy, by 2021 it had actually reached the 95 targets. We haven't seen what the models were predicting. So here you can see the number of infections, the number of people living with HIV has actually continued to increase in Botswana. Even though ART coverage has increased, and over that time of increasing ART coverage, deaths did drop. You can see AIDS-related deaths there in the right-hand figure. But over about the past decade, the decline in deaths has remained almost completely stable. We haven't seen much decline in the number of deaths. And this isn't just in Southern and East Africa that we're seeing this. So I spend most of my time working in Southern and East Africa, but I've looked at some of the data from the Asian Pacific region. If you look at the Philippines, for example, this is what we're seeing at the moment there. You can see that the number of people living with HIV is increasing very rapidly, even now. ART coverage nowhere near as good as has been achieved in Africa. And the number of AIDS-related deaths are not declining at all. They're actually increasing very rapidly in some countries in this region. And globally, we've already heard from Professor Lay, we're seeing about 600 to 650,000 AIDS-related deaths still, right now, even though we have antiretroviral therapy widely rolled out across the globe. So advanced HIV disease, which I think we thought would disappear, has really become something of a neglected disease. So the messaging has changed. We've tried to destigmatize things. We've tried to stop speaking about AIDS, but it's not stopped killing our patients. And the reason that we called it a neglected disease in this article that we published last year was because global targets really have focused on testing, on starting people on treatment, and on viral suppression. They've moved away from monitoring deaths. They've moved away from monitoring opportunistic infections. And the funding has followed that. So the funding's really gone down the route of trying to diagnose people early, to get them started on treatment early, and to get them virally suppressed. But despite that, as I've shown you, the reduction in AIDS-related deaths has been smaller and slower than expected. Many of these deaths can be prevented. Advanced HIV disease was mainly viewed as a problem of late presentation, but I'm going to show you over the next few minutes why that's not the case. And the leading causes of HIV-related deaths seem to have changed little over time. So we'll run through these aspects now. So why are we still seeing advanced HIV disease? Well, one reason still is late presentation. These were some data that were presented at CROI last year and published early this year from a large collaborative group of cohort studies. This is looking at the prevalence of CD4 count less than 200 at the time of diagnosis across the world. And you can see that it remains very high across all regions of the globe. So by 2019, 2020, about 30% of people who were starting antiretroviral therapy globally had advanced HIV disease. So we still haven't cracked the problem of late presentation. And you can see in the Asia-Pacific region, it's slightly better than some places, but it's still a large proportion of people who have advanced HIV disease at initiation. These are some regional data. This is some more recent data from Thailand. 37% of people in Thailand are initiating antiretroviral therapy with advanced HIV disease at the moment. In the Philippines, the proportion is very high. So this is a regional and a global problem of late presentation. In our cohorts in Africa, what we're seeing, though, is that most people presenting with opportunistic infections are not people who presented late to care. These are people who've actually presented they've been diagnosed as living with HIV, they've been initiated on antiretroviral therapy, but then they are not remaining on antiretroviral therapy, they're interrupting care and developing advanced HIV disease. This is a cohort from Uganda where about 70% of people presenting to hospital with HIV-related opportunistic infections have previously been diagnosed with HIV and started on antiretroviral therapy. So our notion that the care cascade is linear, that people start, they get diagnosed, they start treatment, they become virally suppressed, is simply not correct. The care cascade is cyclical. Life is complicated. People don't just start treatment and stay on treatment. Things interrupt their therapy for whatever reason. They stop treatment, they cycle back into care. So there's this cyclical cascade of care. And I think we've really underestimated just how important this is and how much this is going to drive both HIV transmission and advanced HIV disease. So these are data from South Africa, which has one of the best antiretroviral treatment programs on the African continent. This was a very large cohort of patients, about 70,000 patients followed up. And there was a cumulative incidence of treatment interruption of 71% within the first 5 years. So within the first 5 years of treatment, 70% of people interrupted their antiretroviral therapy treatment at least once. 70%, that's the majority of people starting treatment. And these interruptions weren't short. The median duration of a treatment interruption was 7 months, which is plenty of time for your CD4 count to rapidly decline back to its nadir and for your viral load to shoot back up to very high levels. What can we say about this cyclical care cascade in the region? Well, the data are not very good. People don't collect this kind of data through the conventional monitoring systems. But if you look at studies where they have tried to do this, it looks like it's the same everywhere. These are some data from Myanmar, a large cohort again of about 40,000 people in a Médecins Sans Frontières treatment program. And you can see that about a third were lost to follow-up at least once. They had a slightly more stringent definition of lost to follow-up than the South African study. 2/3 of these re-engaged in care, and at the time of re-engagement, the majority of them had advanced HIV disease. So the reason that we're seeing a lot of advanced HIV disease is a combination of still that late presentation, but more and more the fact that people are cycling in and out of care, and when they come back to treatment, they have advanced HIV disease. And of course, that issue won't be solved by expanding our HIV testing and rapidly starting antiretroviral therapy. That will only be solved by focusing really on how do we retain people in care, how do we provide services that are going to enable people to stay on therapy. When people do develop advanced HIV disease, many of them are admitted to hospital. In high HIV prevalence settings across Africa, still a very large proportion of all hospital admissions are people living with HIV. So the top paper is a recent one from Uganda, where 20% of all hospital admissions are people living with HIV. In Botswana, where I've worked, 42% of all medical admissions are people living with HIV, mainly because of opportunistic infections. So it remains a major problem. What happens to people in hospital with advanced HIV disease? Well, bad things on the whole. The in-hospital mortality rate ranges from about 15 to 20% in this large global meta-analysis. It's the same in the Asian Pacific region and low and middle income countries here. And not only do many people die in hospital, but when we send them home from hospital, many of them die in the first few months post-discharge. About 20% of people will die shortly after we send them home from hospital. This was a study presented at CROI last year and recently published in JAMA, looking at some interventions to try and reduce that post-discharge mortality, where they gave enhanced linkage, enhanced counselling. They made sure that people were getting to their HIV clinic. It made no difference to mortality. They still saw almost 20%, 17% mortality. And the reason for that is that people are not dying because of a lack of social support or a lack of linkage into clinic. They're dying because they've got undiagnosed opportunistic infections at the time of hospital discharge or shortly thereafter, which we need to address with medical interventions. So why are people dying and what can we do about it? Well, if you look at the causes of death of people with advanced HIV disease, it's remarkably consistent globally, and it's remarkably consistent over time. It's tuberculosis, it's disseminated fungal infections like cryptococcus and talaromycosis if you're in regions where that's prevalent, it's bacterial infections. This is the same in Uganda, it's the same in Thailand, it's the same globally in our recent systematic review and meta-analysis, which is, if you want to look at it in the appendix, it breaks this down by region, by sex, by all sorts of other things. And we heard a bit about funding cuts first thing this morning. This problem is not going to get better. If anything, as funding is withdrawn from many HIV treatment services globally, we're going to see more and more advanced HIV disease. In most of Southern and East Africa, the majority of HIV care and treatment was funded by the US government, so up to 70% or 70% of the entire global HIV response was funded through US funding. As you know, the majority of that funding has been withdrawn. In some cases, all of it has been withdrawn. And the consequences are going to be severe. These are model data published in The Lancet 2 weeks ago, looking at the impact. They looked at several scenarios of what would happen with proportionate cuts if we reallocated just the prevention budget to treatment, if we discontinued PEPFAR support with other partners stepping in with mitigation, or if we discontinued PEPFAR support with no mitigation. And you can see that with no mitigation, we're anticipating about 3 million extra deaths over the next 5 years, 3 million deaths. And just to be clear, it is that scenario 5, loss of PEPFAR support with no mitigation, which is what is happening at the moment. Nobody is stepping in to fill this funding gap. That's what we're seeing across the African continent and presumably across some of the Southeast Asian and Pacific region as well. So we're facing a catastrophe really in HIV, and we're going to see more advanced HIV disease and more people dying of AIDS unless something is urgently done to remedy the situation. Now, I haven't got long left to talk about what the title of the talk was, which is what we're doing about it and what the WHO is doing about it. So the World Health Organization does have guidelines about advanced HIV disease. These were released in July 2017, so 8 years ago now. They include a package of care mainly focused on outpatients with CD4 testing to identify advanced HIV disease, and then a package of screening and prophylactic interventions, cotrimoxazole, screening for cryptococcal antigen and early treatment of cryptococcal infection, screening for tuberculosis and TPT, and rapid ART initiation. And there are a number of other WHO guidelines which are listed here. I won't run through them all, addressing advanced HIV disease. But there needed to be an update to these guidelines and a consolidation of these guidelines. So we undertook recently a research landscape mapping exercise in advanced HIV disease. And the purpose of this was to outline what the current research landscape is in advanced HIV disease, with the aim of guiding decisions regarding the need for and timing of updates to WHO guidelines. We focused on these key focus areas, which I hope you will agree are broadly sensible. And in each section, there was a brief overview of current and planned research activities, anticipated timelines, and projected implications. And I'll just run through these very quickly, but I encourage you to go and look at this document and read this document. The first aspect was around CD4 testing. Globally, we're facing a major problem with CD4 testing. Since we've moved to treat all, since we've removed the need to have a CD4 count to define eligibility at baseline, people have stopped doing CD4 testing. So across the African region, only 16% of people are now having a CD4 count at the time of treatment initiation. So we simply can't identify those who do have advanced HIV disease. You can see in the Asian Pacific region, the blue dot suggests that CD4 testing is less of an issue here than in Africa, but it's still far from perfect. And we're facing a major problem as manufacturers are withdrawing from the CD4 testing market because the profitability of this market has gone as fewer and fewer people are making the CD4 test. So we have major issues with CD4 testing. There are some lateral flow assays coming online that can identify advanced HIV disease. But if you look at that and the time frame around that, these are very complicated tests to perform. They take about 45 minutes per patient. It's simply not feasible in a busy clinic for healthcare staff to be doing this. So the place for these tests remains to be defined. So CD4 testing is clearly necessary, but there needs to be some research around how we implement current point of care tests for CD4 and how we ensure that people are getting CD4 testing. In terms of tuberculosis, there are a few studies specifically looking at the inpatient management of tuberculosis in people with advanced HIV disease, which we'll be reporting probably later this year. One of them has recently completed one of its arms. So we'll be hearing about those soon. In terms of cryptococcal meningitis, we've got some studies looking at the optimal way to treat people identified with cryptococcal antigenemia. Soon looking at more intensive therapy than just fluconazole alone, because fluconazole monotherapy doesn't seem sufficient to prevent mortality in people who are cryptococcal antigen positive, even if they're asymptomatic. So there are trials looking at flucytosine and liposomal amphotericin in this population. Cryptococcus is one of the areas where we've had some success in terms of treatment. We recently published the Ambition trial that just 3 weeks after publication was included in World Health Organization guidance and hopefully is being implemented worldwide, showing that a single high dose of liposomal amphotericin B can be effectively used to treat cryptococcal meningitis with an optimized backbone of fluconazole and flucytosine. Severe bacterial infections, there's almost nothing going on. We don't know much about the epidemiology of these. We don't know much about the treatment of these. This is a real research need. There's one study looking at azithromycin given in asymptomatic outpatients with advanced HIV disease to try and prevent mortality, with results projected in 2027. In pneumocystis, pneumonia, toxoplasmosis, and CMV, I can summarize this slide in about 10 seconds by saying really there's no research going on that's going to have much in the way of guideline update implications soon. These are all very neglected. We use drugs based on very old trials, in fact on very limited data, and we really need to generate more data about how best to manage these infections. Talaromycosis, almost single-handedly down to members of the panel here, has had a lot of research done looking at improving diagnostics, at improving screening and improving treatment, and is an area where the WHO felt we needed updated regional guidance published very soon. Histoplasmosis is another area where it's becoming apparent this is a big public health problem in certain areas of the world. In people living with advanced HIV disease, we identified the need to generate better epidemiological data, better data about the natural history of disease and how to screen and treat this infection. And in terms of other conditions, it's not just infections that people are dying of, it's cancers, and these are quite neglected, and there haven't been much in the way of guideline updates recently. So the outcome of all of this was that we had a guideline meeting at the end of last year to update the WHO guidelines. We'd been very much hoping to have published a revised and updated advanced HIV disease guideline now, but of course, thanks to our friends in the White House, WHO funding has massively been cut. WHO activities have been curtailed, and this has been delayed somewhat, but we are hoping to get this out at some stage this year. The WHO contributed almost a quarter of the entire WHO budget, which has now gone. So advanced HIV disease is an ongoing challenge. We identified many research gaps, including the need to monitor, to gather good data, and to really determine what the scale of this problem actually is. And going forwards, one of the things that's being cut as funding is being cut are M&E systems. So that's really something we need to focus on, because if this isn't counted and if this isn't reported, it will go unnoticed and ignored, and we won't get the resources that we need. So I'm a bit over time, so I'll just finish there by saying that tackling advanced HIV disease is really an essential part of ending the AIDS epidemic. Improved access to antiretroviral therapy is necessary for reducing deaths, but it's not sufficient. The cyclical nature of the care cascade means that we need to focus on retention in care, not just identifying new people and starting them. Donor support for CD4 testing, and in fact the whole of advanced HIV disease, is essential. And measurement really drives action, so we need good data, we need effective monitoring and evaluation, we need to track the number of people who are getting sick and the number of people who are dying if we really want to know how effective our antiretroviral therapy treatment programs are being. We need better tools for diagnosing, treating, and preventing opportunistic infections, and we need to make more effective use of the tools we have. And we need to not forget about advanced HIV disease in this time of funding cuts. So thank you very much. The reference to the documents there, lots of people to acknowledge and thank.